Hello and welcome to this episode of the ASHA podcast. I'm Fred Wyand with the American Sexual Health Association, ASHA. All right, big news. According to the Centers for Disease Control and Prevention, CDC, there are more than 540,000 reported cases of gonorrhea in the US each year, and the true burden of infection is likely much higher than that. Treatment for gonorrhea is tricky because the organism that causes the infection is increasingly resistant to the current class of antibiotics used to treat. But we have had big news over the last few days, though, as the FDA, Food and Drug Administration, just approved two new drugs to treat uncomplicated gonorrhea, gepotidacin and zoliflodacin, both of which are antibiotics that can be taken orally. All right. And we're really lucky today, intrepid listeners. We're going to be talking about the implications of this with our friend and expert, Dr. Jeanne Marrazzo. In 2023, she was appointed as the sixth director of the National Institute of Allergy and Infectious Diseases with the National Institutes of Health. Before that, she was professor of medicine and director of the Division of Infectious Diseases at the University of Alabama at Birmingham School of Medicine. Go Blazers. She was elected to the National Academy of Medicine in 2024, and her research portfolio is extensive. It includes the relationships between the vaginal microbiome and female reproductive tract infections, HIV pre-exposure prophylaxis, something we talk a lot about, hormonal contraception, and really important to us today, the risk of STI and HIV acquisition. So we're going to tap into that knowledge for sure. Dr. Marrazzo, thank you so much for taking time to chat with us today and doing it on short notice.
Fred, it's so good to see you and to be here with my friends at ASHA who've always done a great job keeping these important topics in the forefront of people's awareness.
Thank you for that. And let's jump right into it. So would you talk about the issue of antibiotic resistance and just how important it is to have a new class of antibiotics to treat gonorrhea?
Yeah, it's this is really quite important. So on your first point, Neisseria gonorrhea, which is the bug that causes the clinical syndrome gonorrhea, is really one of the master adapters in the microbial world. It has, since we've known about it many, many centuries ago, continued to evolve resistance, especially in the era of antibiotics, to really what I mean. So when you think about penicillin being developed in the early 1900s, that was originally used to treat gonorrhea, that didn't last very long. And you go through every class of antibiotic that's been thrown at this bug, including tetracyclines, including cephalosporins, including macrolides like azithromycin, and including sulfa drugs like trimethoprim, sulfamethoxazole, or Bactrim. All of these antibiotics have lost some of their potency, if not all of their potency, in their ability to control this infection. So it really is a shapeshifter. It's just very good at eluting the antibiotics that we have thrown at them. The problem with developing new antibiotics for an infection like gonorrhea, and indeed for most sexually transmitted infections, is that it's not exactly a profitable market proposition for pharmaceutical companies, right? Most of these products are going to be used in settings where people are seeking sexual health care. They're often going to be a single or limited dose regimen, none of which really translates to big profits.
Mhm.
So the incentive for people to invest, companies in particular, to invest and then study these products is really low. So one of the things I really want to get to today is the partnership that was behind the zoliflodacin trial in particular, because it's a great example of how we can get products out to people who need them, regardless of their potential for profit.
So what kind of partnership was that? Is that like a government industry or tell us about
It's a little bit of everything. The way that zoliflodacin started was with support from the National Institutes of Health, actually, to do a study that I was involved with, a phase 2 study. And before that, funding the early phase studies that look at safety in small numbers of participants. So it was a government-funded effort. And then after the drug looked good in those early phase trials, it was essentially picked up not just by industry, but then championed by something called GARD-P, which is a global antibiotic resistant development program that has been really empowered to bring people together to stage these late stage trials to get the evidence we need to get the drugs approved. And they've got a variety of ways to fund themselves. But it's a wonderful example of moving things from a sort of more for-profit driven pharmaceutical pipeline into a way that you can test things to get the evidence you need to get them into the public health infrastructure.
All right, so all of that has yielded two new options. So let me ask you about these two drugs. From the patient perspective, is there any real difference between the two medications?
I would say not. And I honestly think your average patient is probably not going to see these really, really soon. If you look at the indications, particularly for zoliflodacin, the indications say to use these drugs only when other options, standard of care options, are not available. Right now, the standard of care for the treatment of gonorrhea is an intramuscular shot of ceftriaxone. So you get an injection. You can imagine that that would be a lot less appealing than taking a pill like these products recommend or like these products make possible. So I think it will be a matter of time before there's a transition over to the use of these products. I suspect also that because ceftriaxone resistance is not yet a gigantic global problem, not to dismiss it because it is actually increasing, and there are some parts of the world, particularly Southeast Asia, that have seen clinically significant ceftriaxone resistance. I do think there will be a gradual shift away from not just ceftriaxone as the sole class that we're using, but also as a method that requires injections, because we would really like to get away from anything that requires more training, infrastructure, and resources.
Hmm. That's an interesting point. I was curious. Understandably, people are needle phobic. Do folks not get treatment because of needles? I mean, how much of an issue is that?
It's a great question. When you talk to people in different settings, you find out that there's actually a wide spectrum of both tolerability and desire for a needle delivered product. There are some people who are very used to going into healthcare settings and coming out with a shot, because a shot is something that is viewed as medicine and will make them feel better. And
Sure.
some people actually don't believe they've gotten medicine if they don't get a shot. Again, attitudes towards healthcare are so complex and so international. It's hard to make any generalizations. I would say I would hope that people would really just want to get treated. I mean, obviously, when you have symptomatic gonorrhea, you're not going to want to sit around and just wait until a better option comes up in the next month. For most people, if it's asymptomatic, of course, that's a whole other issue. But I do think that most people probably, when they need to get treated, will get treated with a shot.
All right. You just mentioned asymptomatic gonorrhea. Yeah, people with gonorrhea infections don't always have,
Mhm.
especially women, right? They don't always have obvious quick symptoms. What why is this so important to treat gonorrhea? What can happen with undetected infection?
Yeah, great question. So for women, you're right. It's often asymptomatic, and the problem with that is that when it's asymptomatic, it's infecting generally the cervix, which is the bottom of the uterus, the opening into the uterus, of course. And if it's untreated, it can then ascend into the upper pelvic reproductive tract, so the uterus, the fallopian tubes, the ovaries, and that's what sets women up for pelvic inflammatory disease, which we know is a prelude to infertility, chronic pelvic pain, tubal pregnancy. So the rationale for treating asymptomatic STIs in general in women has been that it's been associated with a reduction in certain kinds of pelvic inflammatory disease. So that's one big reason to treat women. The other, really, two other reasons. In some studies, it has clearly been defined as a cofactor increasing risk of HIV acquisition and transmission. If you have HIV and you have gonorrhea because of the inflammation, you're more likely to transmit HIV. And then the third thing, so potentially treating that might reduce your risk of transmitting or acquiring HIV, although that has never been definitively shown in a clinical trial. But then the third thing is really related to antibiotic resistance and asymptomatic infection at the pharynx or the throat. So we know that infection at the oropharynx, the throat, is very common and in people who have gonorrhea. And it's a great place for the bug to pick up these other little snippets of genetic information that can help it develop resistance, because there are other related bacteria that live in your throat that are also Neisseria species. And they've evolved over time to become quite resistant to many antibiotics. So it's a little bit of a breeding ground for the bug to sort of do its thing in terms of picking up resistance factors. So it would be good if we could eradicate that potential reservoir.
No doubt. All right, so you just really made the case of why women are one priority group here. That makes sense. And annual testing for gonorrhea is recommended for, I think, sexually active women younger than 25, and also older women if they have risk factors like, say, multiple partners. Another priority group would be men who have sex with men. They're also recommended for annual testing. And would you just talk about why it's so important that MSM are included in these conversations?
Yeah, well, some of it relates to the fact that I just mentioned about HIV transmission and acquisition. Now, PrEP or pre-exposure prophylaxis has really changed the landscape here, because if MSM in particular are, or men who have sex with men, are adherent with PrEP, either on an episodic basis or on a regular basis, they reduce their risk of acquisition of HIV practically to nothing. So it's a really, really potent tool. That means that STIs in this group, non-HIV STIs, have really enjoyed a pretty healthy comeback. So we're seeing more gonorrhea, particularly pharyngeal gonorrhea, but also rectal and urethral gonorrhea. And I think it's just a really, in addition to obviating any chance for inflammation to maybe get around PrEP, although I don't think that really happens very often at all, if at all. It's just really important in terms of sexual health and transmission to partners, including women, because of course people are sexually active with people of different stripes and sorts of things. So I think it's really important to recognize that we are seeing more infections in this group. We do want to detect them early. We also want to detect them early and treat them so that we can forestall this particular environment promoting antibiotic resistance, which, as I mentioned, is a concern in the pharynx in particular. So lots of reasons to look and to find and to treat.
All right, final question. All the fantastic tools in the world don't really matter much if a patient isn't in care. And we know there are a lot of barriers that prevent people from seeking healthcare, especially sexual healthcare, which is so stigmatized in a lot of ways. Um, I just want to ask you about that in general. And I mean, we're all about trying to empower patients. So, like, if you were doing a 30-second elevator speech to someone to make the case for this is why you need to get tested, this is how you can navigate the uncomfortable parts of it, just you're so good at this. What would you tell somebody?
I would say that sexual health care is primary and personal health care. You care about your body, you care about the people that you are in intimate contact with. And so you want to make sure that you're your best self in all parts of your body, right? And the shame and stigma around sexual health, I wish we could just make it disappear. Because people really should understand that this is an important part of who we are. And it's important that we bring our best selves to whatever we're doing, including our sexual encounters. So that's kind of how I look at it. I think normalizing it and helping people make safe, responsible choices is really what's most empowering for them and ideally keeps people healthy in the long run.
I still dream of a day when we can talk about sexual health issues with our healthcare providers the same way we talk about our flu shots and our cholesterol. So there you go. All right. We have been talking with Dr. Jeanne Marrazzo, our guru when it comes to infectious diseases and a lot of other things. Dr. Marrazzo, thank you so much for helping us sort this out. This is good news, and I really appreciate you helping us understand just why it's such good news. Thank you.
Thanks, Fred. Thanks for covering it, and take care.
Absolutely. Okay. Thank you, intrepid listener, for joining us as always. Keep in touch. We're at info@ashasexualhealth.org. Send along any comments or topics you'd like us to cover in the podcast, and we'll see you next time.